So the first one is about helplines. It says, is the helpline mentioned by the lupus nurse available for us all to use? What's its number for it? If so, perhaps I could hand that over to Carol. What do you think?
Well, thank you very much. Our helpline is primarily aimed at our patients. However, if other people do ring, and people do, we always try and signpost you to your consultant team, and certainly there's a helpline at Southampton, and I think Claire at Winchester has a helpline as well, so these may be more common than you realise, and please do access them. So hopefully you'll be able to access your local one. Is that okay?
I have a question here. If you're taking vitamin D tablets and take calcium, is there anything that you can do to increase, I think it says increase the vitamin D if you're still low? And the answer is yes. Most calcium and vitamin D tablets only give you a small amount of vitamin D. You should still have your vitamin D levels checked. And if they're low, there's a very strong vitamin D called Pro D3, and sounds absolutely scary because vitamin D is 400 units twice a day. Pro D3 is 60,000 units once a week, which you should take for 3 months, and it's safe, but you do need that sort of level to build up your vitamin D. So there is that as an alternative.
Sorry, could I just say, we are finding significant improvements in people's fatigue levels having their vitamin D corrected. So what we need to go is for small gains, and we're doing this more and more. So if you haven't had your vitamin D level checked, when you're having your blood test, have a word with whoever's looking after you and see if it's appropriate for it to be added, because you can't guess these things, we just need to check.
And then attached to the vitamin D quiz, there was also a question about, and I think this says, are there any particular vaccinations that may affect lupus? I think the general advice is that vaccinations that you would normally have should be given. If we immunosuppress patients, then we might make it more likely that they have infection. So having the annual vaccine for influenza, having a pneumococcal vaccine to stop pneumonia, those are good things, ideally in advance, although you possibly can't always do that if someone's ill. There is some evidence, though, that some people seem to have flares of their disease associated with vaccinations, and I think that literature exists, but I think the overall advice would be that for most people it's better to give them their vaccinations rather than withhold them.
Another one. Somebody's asked, they've been taking tablets for the bones once a week for 10 years, and the bone density improved, and they then correctly stopped it, because with these bisphosphonate drugs, we do recommend a break of treatment, a holiday from treatment after about 10 years. The person's now stopped it for 5 years, bone density's dropped. What to do now? Well, if you've had a holiday from treatment for at least a year, it's safe to go back on one of the bisphosphonate drugs, that is the weekly tablets. Alternatively, there's this newer little vaccination-like injection twice a year called denosumab, which seems particularly good, and so that would be a good alternative.
I mean, once again, it's always with risk and benefit, but it is also about lifestyle. So we do see people that as we naturally, 10 years down the line, we're less mobile. So it's once again looking at other risk factors. So making sure you are, what exercise you're doing, and looking if you are getting older and having risk for falls, because that may steer treatment. But also it's about those lifestyle. And we see that people still invest a lot of time in their medication, but not the lifestyle choices, and that's just as important.
Okay, so I've got a question here which is about HRT, and I guess there are probably a few more things we could say more broadly. The specific question about HRT is about, and I don't think it gives away anyone's name, but they've put the question in here. A 68-year-old lupus patient, been on HRT for almost 30 years, who's had no problems with it, but the GP really keen to stop it. Now, I'm not an expert on making decisions about HRT. I have a number of patients who have been on HRT for a long time and feel very well taking HRT. And personally, my philosophy would be that's for the individual and their doctor to decide. I see no specific reason why someone shouldn't be on. I think it's a personal decision for a woman. But there are, of course, some small risks associated with HRT use over time, slightly increased blood clots, slightly increased risk of breast cancer. And an individual just has to weigh that up. But the general advice has been for people to be on HRT for 5 years plus and then to stop, and that's generally what's done. I personally would have a slightly more flexible view on that. I don't know if anyone else feels differently.
Very much agree. Here's a question about bone density in teeth. A recent dental checkup showed that the jawbone holding the teeth was slowly getting thinner. Very good question, and quite a complicated one when it comes to treating bone density. Bone density, your teeth don't tend to lose mineral with age the way your bone does, but the bone holding your teeth, locking them into the jaw, often does get a bit thinner, and that's why people start getting gaps between their teeth as they get a bit older, and sometimes the dental x-ray will show some thinning. So osteoporosis does affect the jawbone, but generally not the teeth. There are issues because I may have touched briefly on the fact that the bisphosphonate drugs may carry a very tiny risk of jaw crumbling of the jawbone. It's very, very rare. But if you're taking these drugs, there is particular advice to dentists about keeping your mouth clean, using mouthwashes. If you're having a nasty extraction done or implants done, making sure that they do very clean and careful surgery, dental surgery, and watch out for infections. So lots of things there to do with these drugs and bones, but not specifically the teeth.
Okay, thank you. We've got a question here. My blood results show my markers are down and my haemoglobin levels are normal, but I have active symptoms of mouth ulcers, extreme fatigue and pain and swelling. And yet my consultant says my lupus is not active. Why is everything based on blood results? And I think Colin's going to have a little...
So for some patients, blood tests are important, but not in everyone does they change, and they do normalise for some patients. In general, with a good team, we don't treat blood tests, we treat the patient, so we should be looking at what the symptoms the patient is experiencing and try and work what those causes are. So mouth ulcers can be caused by disease, but they can also be caused by medications. They can be other poor dental hygiene things that cause mouth ulcers. So it's exploring things and breaking them down. Fatigue is an element that even in good disease control, patients still report. We've got patients that would actually, under the BILAG scoring system, be very minimal and low in disease activity, yet their fatigue is something that's an ongoing thing. It's part of your body being deconditioned over years, perhaps, with active disease, and it's looking at strategies to try and improve those symptoms, looking and discussing with healthcare professionals what else we can be potentially doing that doesn't necessarily mean medication, but maybe lifestyle choices. So we definitely, in our team, and I expect in all the other teams, we treat the patient, not blood tests, because blood tests can take you down the wrong line.
Okay.
Thank you, Colin.
So I also have a question about lupus and mental health, and I think there are a number of ways in which the two can overlap, and so there's a specific part to the question that I'll come back to, but when people have lupus, they can, as part of the disease activity, have depression and have features that can look just like other psychiatric illnesses sometimes, and of course that's not everybody, but in some people that can be the case. If someone was being assessed by a psychiatrist for severe depression, for schizophrenia, for those sorts of diagnoses, it would be normal to investigate them and to do things like ANA and antiphospholipid antibodies, and I've certainly seen people in the past in whom those diagnoses have been difficult to work out and difficult to separate out. So sometimes there can be confusion in the diagnosis, and sometimes the diagnosis of a mental illness can look like lupus when it isn't, and sometimes lupus and the reverse can be the case. So it's a complicated thing, but in all situations we need to consider investigating those things properly.
Thank you. I have another bone question. Somebody who received heparin injections during pregnancy because of the antiphospholipid syndrome and had bone scans before and after. They continue to be recommended as having heparin for long-haul travel and around the time of operations because of the antiphospholipid syndrome. Is there still a risk of osteoporosis with heparin? Well, I don't want to be too anecdotal, but thinking about a case I had at St Thomas's when I ran the lupus pregnancy clinic for Professor Hughes, we had a lady who was receiving heparin injections and had what was called transient osteoporosis of the hip and fractured her hip. And rather than purely due to the pregnancy, we felt it was probably due to the heparin. So heparin can cause osteoporosis. In pregnancy, of course, we often give it sometimes for 2 of the trimesters of pregnancy, so sometimes for 6 months or even more in the postnatal period. So often it's quite a long exposure to heparin, whereas for travel, overseas travel or an operation, it would likely be quite a short period. Of course, heparin injections are given to many people in hospital lying in bed, and it's for a short period, and we don't worry about bone density at that time. So the answer is heparin can cause low bone density, it can be associated with fractures, very unusual, and certainly pregnancy where it's been given for quite a long period of time is something we need to think about, but probably not for brief periods of hospitalisation and travel. Thank you.
Okay, so this question has come to us, but it might be for the colleagues in Lupus UK. So this is there a Wiltshire Lupus group? I don't know the answer to that. Is there a Wiltshire Lupus group?
Wiltshire is part of the Western Lupus group, but it's not active at the moment.
Okay. So there's the answer.
But we can put people in contact with someone if they need it.
Okay. Did everyone hear that? So you can be put in contact by getting in contact through Lupus UK nationally. I guess, or through any of the groups, they'd point you in the right direction.
Look in the back of News and Views.
News and Views, all the information's in there. Okay, thank you. Okay, and here's a question. I've had several members of the family with lupus. How far genetic tests come? Well, the genetics of lupus have come a long way in terms of identifying lots of different genes, but in terms of identifying a particular genetic signature that guarantees someone's going to get it, it isn't good enough to use it at an individual level, as far as I know. So if you had a family with lots of lupus and you said, well, I want to screen all of the other family members just to check if they'll get it, or screen the children to see if they'll get it, I don't think that could be done reliably. Part of that is because the disease isn't all genes. And even if you had a woman with lupus and she had an identical twin sister, her chance of getting lupus is probably less than half, even with the same genes. So there are many other things and many other environmental factors involved in it as well. But people are working out which genes are involved, and you won't be surprised to know that lots of those are immune genes. And a lot of those are genes associated with our ability to get rid of immune rubbish. So by that what I mean is, every time you're exposed to something, what you eat, what you breathe in, what bacteria get into you, you smash it up into little bits, you digest it as you eat it, and little bits are floating around your body. Your immune system sees it, it partly reacts, it partly doesn't, and it tries to get rid of those bits, it samples it, has a look at it. And that creates rubbish. Just like in your house there are bits of paper floating around, and your immune system has to get rid of those bits of rubbish and throw them away, and if it doesn't, they stay there, stimulating the immune system. People with lupus often can't get rid of that immune rubbish, so lots of the genes involved are the get rid of immune rubbish genes, which means people can't clear it, and then the immune system is in this state of activity all of the time. So still lots of work on that. So, are there any other questions? Let me just check. I think I've answered everything in my part.
Thank you for the questions, they were really excellent.
Yeah, thank you very much.